Good morning, everyone. Welcome to the session entitled Pediatric HIV Treatment, Old Drugs, New Drugs. I am Ellen Chadwick, a pediatric infectious disease specialist at Northwestern University in Chicago. I'm happy to introduce our first abstract presenter, Dr. Theodore Ruel, from UCSF Benioff Children's Hospital, San Francisco in the US. He will be reporting 24-week safety, tolerability, and efficacy of dolutegravir dispersible tablets in children 4 weeks to under 6 years of age with HIV, results from Impact P1093.
My name is Theodore Ruel, and it's my pleasure today to present these results on behalf of the Impact 1093 study team. I'll be presenting data about the 24-week safety, tolerability, and efficacy of the dolutegravir dispersible tablets in children ages 4 weeks to less than 6 years of age with HIV. Dolutegravir is recommended for first-line treatment of adults and children with HIV due to its potency, high barrier to resistance, and tolerability. A 5 mg dispersible tablet pediatric formulation is being evaluated in Impact P1093, an ongoing phase 1-2 open-label PK safety, efficacy, and dose-finding study. Today, I'll present our 24-week results among participants who received the dose proposed to regulatory authorities. I'll add that the FDA actually approved this formulation on June 18 of 2020, with a hyperlink to the label provided at the bottom of the slide. This slide summarizes our methods. Children were enrolled into 3 age cohorts, 4 weeks to 6 months, 6 months to 2 years, and 2 years to 6 years. Children had to have an HIV RNA of greater than 1,000 copies per ml at the time of enrollment. This could include treatment naive or treatment experienced children who were failing therapy. The dispersible tablets were 5 mg units and dosed by WHO weight bands, as shown in the table below. Children also received an optimized background regimen that included 2 other agents, of which one had to have genotype predicted activity. Clinical and laboratory assessments occur between days 5 and 13, and then at weeks 4, 8, 12, 16, and 24 with 3-day visit windows. Safety data included in this analysis were current to April 30 of 2019. Additional details about the protocol can be found at the Impact website shown by the link below. This slide summarizes the characteristics of our study population, including 51 children. Of them, 55% were female. The majority were recruited from Africa, representing 70%, with an additional 12% from Thailand, 4% from the USA, and 14% from Brazil. 29% of the enrollees were ART naive, and the median RNA at the time of enrollment was 4.3 log copies per ml. The optimized background regimens are summarized in the table to the right. You can see that 47% received abacavir plus lamivudine, an additional 20% received zidovudine plus lamivudine, and a diversity of different regimens received by the other children, but worth noting that 13 of them received lopinavir ritonavir as part of the regimen, and 1 child received both efavirenz as well as darunavir ritonavir. This slide summarizes our virologic efficacy results. It was assessed in 34 or 67% of participants who had 24-week HIV RNA results available at the time of data freeze. In the figure, you can see the proportion of participants who achieved a viral load of less than 400 copies per ml at different time points in the 24-week period. The table on the right summarizes those at the 24-week time point. The first row represents those with viral loads of less than 400 copies per ml. 29 of 34 or 85% of participants achieved that endpoint. The second row summarizes those who achieved less than 50 copies per ml, and that included 18 of 34 or 53%. You'll note wide confidence intervals reflecting the small sample size of this population ultimately. We've also included for reference results from a similarly structured sailing trial in adults, which reported that 87% comparable achieved a proportion at less than 400 copies. 79% achieved less than 50 copies at 24 weeks in that trial. This slide summarizes the virologic and immunologic outcomes of children receiving the dispersible tablet formulation of dolutegravir that's stratified by age cohort. So across the first row, you can see the 3 age cohorts defined with, again, 4 weeks to 6 months, and that was included 17 children. 9 children were 6 months to 2 years, and 8 children were 2 years to 6 years, smaller numbers. Across the first row, you can see the proportion that achieved HIV RNA of less than 50 copies per ml at 24 weeks. That proportion was 41% in our youngest cohort, 67% in the middle, and 63% in the oldest cohort. Across the second row, you can see the proportion who achieved less than 400 copies. In comparison, these were much more comparable across the age cohorts, with 88% in the youngest cohort, 89% in the middle cohort, and 75% in the oldest cohort. Across the bottom two rows, you can see changes in CD4 count and CD4%. Without going into details, you can see that most achieved some degree of recovery, but there were wide ranges in diversity among them, and in some cases even declines. These data were difficult to interpret when overlaid upon normal age expected changes across these time periods. Safety and tolerability is summarized in this slide. All children who received the proposed dose were included in safety analyses. No grade 3 or 4 adverse events were attributed to study drug, and accordingly, study drug was never discontinued due to toxicity. The table below summarizes adverse events of any attribution, or overall, of grade 3 or greater severity. The first row summarizes clinical events, or participants who experienced clinical events. This included 13% of the youngest cohort, 17% of the middle age, and 6% of the oldest cohort. Laboratory events are summarized in the second row. 57% of the youngest cohort, 33% of the middle, and 19% of the oldest cohort experienced laboratory events. Laboratory events included anemia, neutropenia, and clinical events included common infectious diseases such as pneumonia, diarrheal illnesses that are unfortunately commonly experienced in the study population in our study settings and in greater incidence in the younger populations. Tolerability of the dispersible tablet formulation was excellent. The palatability rated as average, good, or very good for 98% of respondents. In summary, the dispersible tablet formulation of dolutegravir was well tolerated, had a favorable safety profile, and demonstrated virologic efficacy among infants and children ages 4 weeks to 6 years with diverse prior ART experience. The variable CD4 changes seen likely reflect multiple factors, including recovery, overlaid upon age-related normal changes. We believe our results support the recent FDA approval of this pediatric formulation of dolutegravir for the treatment of children living with HIV globally. The authors would like to acknowledge the entire P1093 protocol team, site staff, and most importantly, participants and their caregivers. We'd also like to acknowledge ViiV Healthcare, GSK for their team and financial support, and overall support from the NIAID and NICHD of the Impact Trial Network. Thank you.
Thank you, Dr. Ruel, for that very interesting abstract. Dr. Rajendra Singh from ViiV Healthcare in the U.S. will be reporting pediatric dolutegravir dosing recommendations derived from combined P1093 and Odyssey population pharmacokinetic analyses.
Hi, I'm Rajendra Singh. Thanks for providing opportunity to present my recent work. I am presenting results from population PK analysis of dolutegravir for supporting pediatric dosing recommendation. The population PK analysis is based on data from 2 studies, Impact P1093 study and Panta's Odyssey study. P1093 study was a phase 1-2 multicenter open-label PK safety and tolerability study, while Odyssey study was a randomized trial of DTG-based antiretroviral therapy versus standard of care in children with HIV infection starting first or switching to second-line ART. The objective of overall analysis was to perform POP-PK analysis to support dosing recommendation derived from combined P1093 and Odyssey data, and to assess whether there is a correlation between DTG-PK parameters and selected safety endpoints. Overall, 239 subjects provided data for population PK and PK safety analysis. Baseline age was 6.3 years and baseline body weight was 22 kg. Black race constitute almost 80% of data, with white and Asian corresponding to 10% each. Film-coated tablet, granules, and dispersible tablets were the 3 formulations used in P1093 study. In Odyssey study, film-coated tablet and dispersible tablet were used. Data was collected under fasted or without regard to food conditions. One compartment model with first order absorption and first order elimination was used to characterize pharmacokinetics of dolutegravir in pediatric participant. The base model includes allometrically scaled clearance and volume of distribution. Model also include a maturation function as defined by Anderson et al. Inter-occasion variability was used on clearance as well as rate of absorption. The relative bioavailability was estimated for granules and dispersible tablet relative to film-coated tablet. Based on POP-PK model, estimated oral clearance was 1.3 liter per hour, volume of distribution was 13.6 liter, rate of absorption for granules and dispersible tablet was more than twofold higher than film-coated tablet. The relative bioavailability of dispersible tablet and granule as compared to film-coated tablet was 50% higher, and the bioavailability without regard to food was 10% higher than bioavailability under fasted condition. Inter-occasion variability on clearance was 34%, and the inter-individual variability on clearance and volume was less than 30%, while for rate of absorption it is approximately 100%. The extrapolation of doses in pediatric participant is based on adult equivalent exposure. That means if AUC, Cmax or C-trough in pediatric participant within a weight band is similar to adult exposure, then efficacy will be same. For pediatric dose selection, therefore targets were predefined. The targets were based on primarily adult geometric mean data coming from 50 mg QD dose. For AUC, the target geometric mean was 46 with a range of 37 to 134 microgram hour per ml. For trough concentration, the target was 995 with a range of 697 to 2260 nanogram per ml. Maximum lower limits were also set. They were set based on Emax model in HIV infected subject, corresponding to 95% of maximum virological response. For AUC, it was 25 microgram hour per ml. For C-trough, it was 500 nanogram per ml. One compartment population PK model was adequate to characterize data from two studies for dolutegravir in pediatric subjects. This slide shows proposed doses based on population PK model and simulated exposure corresponding to those doses. For example, in 3 to 6 kg weight band for subject greater than 1 month of age, 5 mg dispersible tablet dose is proposed. Accounting for maturation function, in 6 to 10 kg weight band, two different doses were proposed. One 10 mg dispersible tablet for subject below 6 months of age and 15 mg dispersible tablet for subject greater than 6 months of age. In all cases, the exposures were within the predefined target range for both AUC as well as C-trough. No target were defined for Cmax for dose selection. Based on modeling and simulation and exposure safety analysis, doses were proposed for film-coated tablet as well as dispersible tablet. For 6 to 10 kg weight band, as shown in left panel, doses were proposed by accounting for maturation function and they were stratified by age. For subject greater than 6 months of age, 10 mg dispersible tablet dose was proposed. For subjects greater than 6 months of age, 15 mg dispersible tablet dose was proposed. In discussion with FDA, that age stratification was removed, and for 6 to 10 kg weight band, only a 15 mg dispersible tablet dose was finalized. To conclude, the model described data from both study and associated variability adequately based on simulated and observed data. Dose stratification by age was proposed in 6 to 10 kg weight band, where 10 mg dose was proposed for subject less than 6 months of age and 15 mg dispersible tablet dose was proposed for subject greater than 6 months of age. In discussion with FDA, age stratification was removed and 15 mg dispersible tablet dose was approved for 6 to 10 kg weight band. At all the proposed doses, both AUC and Cmax were within target range. The safety exposure response analysis demonstrated no relationship between PK parameters and adverse event. Thank you for your attention.
Thank you, Dr. Singh, for that interesting abstract. Dr. Eva Natukunda from Joint Clinical Research Center, Uganda, reporting safety, pharmacokinetics, and efficacy of low-dose ECF-TAF in virologically suppressed children over 2 years of age living with HIV.
Dr. Eva Natukunda from Uganda. On behalf of the research team, I present the safety, pharmacokinetics, and efficacy of low-dose ECF-TAF in biologically suppressed children aged 2 years and above living with HIV. I report no conflict of interest. Young children, especially those weighing less than 25 kilograms living with HIV, have few ARV options. There is no single tablet regimen used or approved for this population in the US or European Union. TAF has been shown to have a safe bone and renal profile in adults, older children, and adolescents in association with low plasma tenofovir exposures compared to tenofovir disoproxil. The fixed-dose combination tablet of elvitegravir, cobicistan, emtricitabine, and TAF is a once-daily complete ARV regimen recommended as an initial regimen in the US in adults, adolescents, and children at least 6 years of age and weighing at least 25 kilograms. This single tablet regimen has now been co-formulated into a low-dose tablet for children who are at least 2 years of age and weighing between 14 and 25 kilograms. We report today the first PK, safety, and efficacy data of the low-dose tablet of ECF-TAF in children 2 years and above living with HIV. This is a single-arm open-label study with an age-staggered design. The primary endpoints of this study are to determine the plasma PK of elvitegravir and TAF and evaluate the safety and tolerability of ECF-TAF through 24 weeks of treatment. The primary results from cohort 3 are the focus of the present analysis. Key inclusion criteria for cohort 3 included a viral load of less than 50 copies for at least 6 months, CD4 count of at least 400 cells per ml, and eGFR of at least 90. 27 participants were enrolled and all underwent intensive PK testing at week 2. The primary endpoint of this cohort was reached at week 24 and secondary endpoints at week 48. After week 48, participants are offered continued participation in the extension phase of the study. Of the 35 patients screened, 27 were enrolled and all have reached at least 40 weeks. At baseline, the median age was 6 years with a lower age of 3 years. The median weight was 19.3 kilograms and 63% were female. Almost half were enrolled in South Africa, with the remaining half enrolled in Thailand, Uganda, USA, and Zimbabwe. 89% of participants were Black. All were biologically suppressed at study entry, had a median CD4 percentage of 37 and a median CD4 count of 1,600, and a good renal function. Most were infected through vertical transmission. Most baseline ARV regimens prior to study drug were NNRTIs and 2 NRTIs. The PK parameter of area under the curve for elvitegravir and TAF was the primary endpoint in the study. The geometric mean AUC of EBG and TAF in cohort 3 were compared to adult AUC values and were shown to be modestly higher in children than adults. The elvitegravir TAF concentration was slightly lower in children than adults, but was still 9-fold above the inhibitory concentration for wild-type virus. Exposures of EVG and TAF are within the range of historical data in adults, adolescents, and children that have been shown to be both safe and efficacious. Additionally, exposures of cobicistan, FTC, and tenofovir also remain within range of historical data. There were adverse events of any grade reported in 74% of participants, but no grade 3 or 4 adverse events, no adverse events leading to drug discontinuation, and no deaths. The most common adverse event participants The most common adverse events were respiratory tract infections, cough, decreased appetite, and vomiting. 4 participants had adverse events considered related to study drug, consisting of diarrhea, vomiting, asthenia, and decreased appetite. The one unrelated serious adverse event was pneumonia. 1 participant had a grade 3 laboratory abnormality of decreased platelets. eGFR remained stable over 48-week period. Bone mineral density analysis showed that participants mineralized bone according to their reference population. Additionally, no participants had a 4% or more decline in spine or total body lessened BMD by week 48. Over 48 weeks, body weight improved while fewer gains were observed, with height consistent with what has been reported in the literature for children living with HIV on stable regimens. Virologic efficacy by FDA snapshot analysis at week 48 showed that 89% of subjects in cohort 3 were below the threshold of 50 copies per year. Due to COVID-19 restrictions, data was missing in the analysis window for 7 subjects. No subject met the criteria for resistance testing. The CD4 count showed an initial decline at week 2 that was not reflected in the percentage. Both remained stable to 48 weeks. Acceptability and palatability were also assessed by a questionnaire requesting information as to whether the tablet was broken in half to swallow, which was allowed by the study, and how easily it was swallowed, and how acceptable shape, size, and taste of the tablet were for participants. Mean adherence assessed by pill count was high at 97%. Swallowability, a component of acceptability and palatability, were assessed at baseline and at week 4 and 24. The number of children who needed to split the tablet decreased from 4 at baseline to 1 at week 24. Ease of swallowing was high in this population, in which the youngest age was 3 years, and improved over the 24-week duration, and taste was also mainly rated as good or super good throughout the 24 weeks. In conclusion, in virologically suppressed children, ECF TAF low dose single tablet treatment was well tolerated. All AEs were mild to moderate. There were no adverse events that led to discontinuation. ECF TAF demonstrated excellent adherence and maintained virologic suppression. The low dose tablet had a high level of acceptability. Exposures of albuterol and TAF were consistent with ranges of exposures observed in adults in phase 3 trials of ECF TAF. Efficacy and safety were consistent with results from phase 3 trials, which showed high proportions of viral suppression, no resistance, and good tolerability. These data support further pediatric studies of ECF-TAF, which may be an important integrase inhibitor option for HIV-infected young children aged 2 years and above and able to swallow a tablet. Thank you very much. This study was funded by Gilead Sciences.
Thank you, Dr. Natukunda. Professor Juliet Mwanga from Epicenter, Uganda, reporting on safety, pharmacokinetics, and acceptability of the abacavir 3-TC lopinavir ritonavir granules 4-in-1 in children living with HIV 3 to 20 kilos in Uganda, the Lollipop study.
I'm Juliet Mwanga, presenting the Lollipop study interim results on behalf of all the co-authors. Lollipop is a phase 1 to randomized crossover PK safety and acceptability study of 4-in-1 fixed dose combination of abacavir, amlodipine, lopinavir, and ritonavir compared to lopinavir, ritonavir pellets plus abacavir, amlodipine dispensable tablets in children living with HIV weighing between 3 and 25 kilograms. Children were dosed as per WHO weight band dosing schedule. Children from weight band 2 to 5 are randomized to either receive the 4-in-1 or the reference formulation for 21 days. Intensive PK is performed, and then the treatment arms are switched, and children receive 21 days of other formulation. The second intensive PK is then performed, and then children are returned to their standard of care. Children from weight band 1 are not randomized. They receive the 4-in-1 for 21 days, followed by intensive PK, and then return to their standard of care. The 4-in-1 formulation, also called quadrimune, are granules. The size of the granules are optimal for very young children, and this formulation is well test masked. Here we see the enrollment per weight band. 44 children were screened and 33 were enrolled into the study. Of these, 4 patients were in weight band 1, and 29 in the highest weight band, 15 of who were enrolled into the 4-in-1 first, while 14 were assigned to the reference formulation first. Datasets are available for all but 2 children, not included in the PK set. Baseline characteristics for gender, age, and weight are as expected. All the children were already on lopinavir-based therapy, and 76% of them had been on NRT for 6 months or more at the time of enrollment. 29 of the 33 children had viral load below 400 copies per mil at baseline. The proportion of children with viral load less than 400 copies per mil increased from 87% at baseline, that is the blue box, 97% at the end of the study, that's the red box. The proportion with viral load less than 50 copies per mil increased from 48% to 65% when excluding the missing data. The median change in CD4 cell count was 130, and on average, there was no change in CD4 percentage. In terms of safety, 101 treatment emergent adverse events were reported. 96 were mild, 4 moderate, and 1 severe, none led to treatment discontinuation. 1 was serious bronchopneumonia, which started while on reference formulation. The most common adverse event were vomiting, 52% of the episodes, and all treatment-related adverse events were of grade 1. Here we see the PK results for Abacava. The blue curve shows Abacava in the 4-in-1, and the red curve shows Abacava in the reference formulation. These 2 exposure curves overlap nicely. The area under the curve target was extracted from the arrow study and the Abacava package insert. The geometric mean ratio for area under the curve is 49%. The Cmax geometric mean ratio for Abacava is 24% lower. The bioequivalence criteria were met for Abacava area under the curve. Here we see the PK results for 3TC. As before, the blue curve shows the 3TC in the 4-in-1, and the red curve shows the 3TC in that reference formulation. The geometric mean ratio of 4-in-1 for area under the curve is 82%, and the Cmax is 69%. Neither area under the curve nor Cmax met bioequivalence criteria, but were comparable to historical exposures in adults and children. Interestingly, 3TC exposure with 4-in-1 were closer to historical values. Here we see the PK results for lopinavir in the 4-in-1 and in the reference formulation. The GMR area under the curve was 12% lower with the 4-in-1, and lower confidence interval lay outside the bioequivalence range. The lopinavir Cmax geometric mean ratio was 17% lower. Absorption of lopinavir was slower with the 4-in-1. Overall, the lopinavir exposure was comparable to historical data in adults, and exposure with the 4-in-1 were closer than those with the reference formulation. 2 of the 4 children with weight band 1 and 1 child in weight band 4 had C12 below 1,000 nanograms. Weight band 1 includes a heterogeneous population of children, and we are currently gathering more data in this weight band. If we look at the characteristics of the weight band 1 children, the first 2 had with a low exposure are aged less than 5 months at the start of the study and presented either with comorbidities or suspicion of prematurity. The 2 other children aged 8 months had a very low weight at screening with severe malnutrition. All children gained weight in 21 days, and their virological suppression improved on treatment. Food did not appear to impact on exposure. Here we see the exposure of lopinavir by formulation according to the expected upper and lower target exposure stratified by weight band. In weight bands 2, 3, and 4, exposure to lopinavir is very close to the expected ranges observed in adults. For weight band 1, the target range is based on that observed with liquid formulation in children. We see wide variability with the 4 children all enrolled to date. Given the small number in the weight band 1 children, we cannot yet draw a firm conclusion, and so more children are being recruited in this weight band. As conclusion, Weight band 2 to 4 demonstrated comparable drug exposure. 2 children in weight band 1 had C12 below 1,000 nanograms. 4-in-1 was well tolerated, including in weight band 1 children. 97% of children were virologically suppressed at the end of the study. Children in weight band 1 had a decline in viral load after 21 days of exposure. The study is ongoing and final results will be available. And details about acceptability of this new 4-in-1 formulation are presented during this conference. We thank children and caregivers who participated in the Lollipop study in Uganda, as well as all study staff, partners, and the sponsors. We thank Unitaid for their support and thank you all for listening.
Thank you, Dr. Mwanga. Dr. Jason Bacha from Baylor College of Medicine Children's Foundation, Tanzania, reporting on the DTGs of DTG for children and adolescents living with HIV, or CAL-HIV, descriptions, trends, and gaps of rolling out dolutegravir in CAL-HIV in Mbeya, Tanzania.
Hello, ladies and gentlemen, and friends and colleagues. My name is Jason Bacha from the Baylor College of Medicine Children's Foundation, Tanzania, and the Baylor International Pediatric AIDS Initiative. And I'm excited to present the findings from our study titled The DTGs of DTG for Children and Adolescents Living with HIV. Descriptions, trends, and gaps of rolling out dolutegravir in children and adolescents living with HIV in Mbeya, Tanzania. The background to the study, as I think we well know, efficacy and safety data of novel ARVs in children often lag behind the adult data, and this lag can lead to hesitation and slow uptake by prescribers of using new ARVs. Regarding DTG specifically, some of the early trial data has been reassuring in children, specifically the IMPACT and Odyssey, but of course it's small sample size and hard to know how it will translate to real-world settings where the medicine is used and needed the most. In 2019, Tanzania procured DTG, updated guidelines, and began a country-wide rollout. And therefore, to try to understand better the use, the safety, and efficacy of DTG in Tanzania, we studied and described the characteristics and outcomes of this rollout in children and adolescents living with HIV treated with DTG in our clinic in Mbeya, Tanzania. The methodology we used, we did a retrospective chart review to describe these characteristics and outcomes of children who were prescribed and given DTG as part of their ARV regimen. The site, again, was the Baylor College of Medicine Children's Foundation Tanzania Center of Excellence in Mbeya, Tanzania, which is in southwestern Tanzania. The inclusion criteria of our cohort was children and adolescents ages 0 to 19, HIV positive, who are on ART and in care at the Baylor Tanzania Clinic in Mbeya. And the dates of analysis were through the 1st of March 2019, when DTG became available at our site, through the end of that year, 31st December 2019. Also of note, we defined HIV viral load suppression as less than 1,000 copies per the WHO in-country guidelines. What did the results of our study show? We had 681 patients who received DTG at the Mbeya COE during the time of study in 2019. The 681 made up 46% of all patients on ART at our center and 60% of patients who are eligible to receive DTG, defined as having a weight of 20 kilograms or more. The pie figure below shows the distribution of regimens used. You can see the majority of patients receive the TLD fixed dose combination. The table on the right shows the baseline characteristics of our cohort. There was a nice split of male-female. The average age was right around 14 years of age, ranging from 5 up to 19. The time on ART was average of 5 years, again ranging from new initiations up to 14 years of ARV exposure. Baseline WHO stages of the cohort showed over 60% with a stage 3 or 4, reflecting the complex care and complex patients we see at our center. But thankfully, through the course of the study, 98% of patients were able to be a WHO treatment stage 1. Also of note, we had about 60% of our patients with some form of severe or moderate malnutrition, again, reflecting the complexity of patients in care at our center. And as for the ART status of this cohort, 12% were new ART patients with new initiations. The remainder were shifted from prior regimens, with the majority, 62%, that had been on NNRTI regimens. As for our outcomes data, we had very reassuring data with 0 patients having any severe drug toxicity or negative outcomes. Of the patients on DTG, 95% of the cohort remained actively and safely in our care, while the remaining 5% were successfully transferred out, and we had 0 deaths and 0 loss to follow-up. Also, of our DTG cohort, 77% were able to utilize multi-month prescribing. The figures on the right, the upper figure shows viral suppression rates pre- and post-DTG amongst our cohort with viral load results. Prior to the DTG, 77% were virally suppressed, and at the end of the study, post-changing to DTG regimens, 84% were virally suppressed. The bottom 2 figures, on the left it shows of patients with viral loads pre and post who were initially unsuppressed. We were able to suppress 63% of those patients by using a DTG regimen. Likewise, of patients previously suppressed who were changed to DTG, 95% were then suppressed through using DTG. So in summary, our study showed that DTG was very well tolerated and quite effective in our clinically diverse cohort of adolescents and children living with HIV. Again, there was no toxicity, no adverse events, no deaths, no issues with DTG. It also showed that the use of DTG resulted in viral suppression for many of our previously unsuppressed patients. And these results, we hope, are very encouraging, and that they show that DTG can successfully and should successfully be used in children and adolescents living with HIV. Thank you very much for your time and listening to this presentation.
Thank you, Dr. Bacha. And finally, Ogara and Collin from Makerere University, Uganda. Acceptability of a new 4-in-1 abacavir, lamivudine, lopinavir, ritonavir pediatric fixed-dose combination, the caregiver child dyad's perspective.
I would like to thank the organizers for the opportunity to present the qualitative results of the Lollipop Acceptability Study. I am Ogara Collin, a qualitative researcher on this study. So, we set out to investigate a new 4-in-1 pediatric fixed-dose combination of abacavir, lamivudine, lopinavir, and ritonavir, which was developed by CIPLA in partnership with DNDi for use in low-resource settings where infants and children have challenges swallowing tablets. Overall, this study is also presented at this workshop. So what was the objective? The objective was to assess caregivers' perceived acceptability and related factors of the 4-in-1 formula compared to pellets and tablets. Under the methods, we are saying that it was an open-ended randomized crossover pharmacokinetic safety and acceptability study. And we purposively sampled and administered 18 semi-structured interviews to caregiver diets between 3 to 19.9 kilograms. Interviews were conducted after the 21st day of the 4-in-1 as shown in the figure in this slide. We use an inductive thematic analysis with support of a computer software called NVivo version 12. So now I move to the results. And I first want to talk about caregivers' perception regarding caregivers' acceptance of the 4-in-1, and later on, I will talk about the factors related to their acceptability. In overall, the caregivers had a better experience of the 4-in-1 than any other formula. For example, the syrups and pellets that they previously used. Hence, the 4-in-1 was highly acceptable. On matters of children's acceptance, we want to say that most children enjoyed it because it was sweet. As one of the caregivers noted, she likes and enjoys it because she responds very well. She does not become nervous when she is taking the formula. Now I want to move to acceptability factors relating to the formulation and storage. Many felt that the 4-in-1 was easier to store. This was because it is kept at room temperature, unlike previous formulas. In addition, the formula 4-in-1 had an average 5 minutes time taken for administration compared to others, and this gave caregivers a better perception about its. As one of the caregivers noted, another good thing is that it is stored at room temperature than the first ARV syrups, which required someone to find a fridge to keep them safe. Now I want to talk about acceptability factors relating to the packaging and testing. So generally, the packaging was received well by most of the caregivers. However, for a few who said the bottle was too big. And then for the children, the taste was nice for the 4-in-1, as I said earlier on, so it was sweetish. And this is backed up by experiences where one of the caregivers noted that their experience has been good and easy. Oh, this formula is an easy form because you just open the capsule and pour it in honey, porridge, or milk and give it to the child. Now I want to move to aspects around factors related to caregivers' acceptability. And here we are saying information and adherence. And under information and adherence, caregivers learned easily how to correctly administer the 4-in-1 because they knew the effects of a missed dose. As one of them noted, not adhering to the drug, the child's soldiers reduced, meaning a high viral load. Under motivation, the caregivers had witnessed positive results of the 4-in-1 in the short run or in the short term in terms of weight and growth of their children. And this gave them a ray of hope that their children's future was bright. For example, one of them said, when my child grows up, I would like him to become a doctor so that he can also treat others. Now I want to move to issues around caregiver skills and innovation. And I want to say many of the caregivers adapted innovative approaches to remind them and keep time. For example, alarms on their phones and others. As one noted, I set my alarm at 8 a.m. and 8 p.m. and that is the time I give my child medicine. Finally, I want to move to the aspects of support needs. And we are saying caregivers, through counseling and tips to administer the 4-in-1 by the health workers, were very influential in acceptability, yet this study was short, so in the short run adherence. As one of them noted, the first day I started using the 4-in-1 formula, I poured the powder, that is like millet, on a spoon and put it in the mouth of the child, but it made him tend to vomit. So I asked the doctor, who advised me to mix the medicine in 2 little porridge and then give the child. This method worked very well for me. In conclusion, I want to say that the 4-in-1 is a better accepted pediatric formula than other formulas previously used. I also want to say that acceptability was greatly influenced by the formula itself in terms of test, ease to administer, and storage. And finally, I want to say individual motivation and tailored specific support to caregivers influenced acceptability. Thank you very much for listening to me, and I want to acknowledge all those who supported this study to take place. Thanks a lot.